Good morning. My greetings on the World Health Day. Respected Dr. Rajendra Pratapji, distinguished colleagues from medical fraternity, from our other nations, diplomats, members of the IPU, and above all, the patient community, the citizens present in this room. I am truly pleased and honored and privileged to be here. Thank you for the invite, Rajan. And to be able to attend the session, which is so important for the work that I undertake, I discharge under the leadership of the Honorable Prime Minister. Let me first and foremost submit that reaching a stage of high quality health system, patient-centric health system, caring health system, and a health system that has access, does not impose out-of-pocket expenditure, the financial stress, and encompasses prevention, health promotion, treatment, rehabilitation, is a journey, is a long journey, and it's a journey that we are traversing at this point of time. इस कालखंड में हम उस जर्नी में चले हुए हैं. Fact also remains that these journeys are never over. If you look at the West, they're continuously refining. The health systems are under challenge in Europe, in the Americas, and so on. But we are passing through a journey where the aspirations need to be met. But keeping in mind that our current state of economic prosperity, though improving and will improve even more speedily, imposes limitations because we are not yet a developed nation. We aspire to be a developed nation by 2047, and I believe that strong health system is an enabler of being a developed nation. But this journey for the health system that we expect and our families expect is still an ongoing process. That's a humble recognition and humble, I would say, realization for all of us. We are at under $3,000 US dollar per capita income. We aspire to reach a level of 18,000 per capita by 2047. But even then, let me start with, some optimism. And what India has been able to achieve, all of us as nation have been able to achieve. At the time of independence, the life expectancy estimated by the famous Bohr Committee report, or Bohr Committee, that was 1946 actually, 44, 45, 46, was 27 years. 27 years, let's say under 30. In 1947. Today we are 71. At that time, the life expectancy of Great Britain was 58. So they had given us half the life expectancy of what they had, and they thought they were helping us. 71 years is what we have now. We aspire to take it to 85 years by 2047 because that is the typical life expectancy of nations in Europe. In fact, US is about 2 years less, but 85 is a great number to work with, and we believe it's possible. It's a secular trend, but it has to be accelerated a little more for us to achieve that. It will not happen automatically. That's the point. Let me also bring in today's World Health Day, and the focus this World Health Day is on women and children, particularly newborns. So I have data points to just tell you where we are with regard to this crucial element. And it must be stated today in particular. In 1990, the maternal mortality ratio was 556 per 1 lakh live births. In 2020, we are down to 97. The SDG target is 70. The SDG target is 70. 8 of our states have already achieved the SDG target, with Kerala being so low, just like any other developed nation. So we are on track to reach the SDG goal of 70. And I think the data, whenever now it comes, it will not be 8 states, but perhaps at least 4 or 5 more states. The world in this period declined maternal mortality ratio by 42%. That's what the world did, average. We declined it by 83%, double. That's what this nation can do. 83% versus 43 and 97, and on track to achieve 70. We understand all the issues that have been done. Most humbly, I've taken notes, I've embraced them. Whatever is my domain and more, I promise that I'll work for that. Under 5 mortality. Under 5 mortality per 1,000 live births. 1990, 126. Today, 2020 actually, is 32. We pushed it by 3/4 in this period, whereas the world pushed it by 58%. The the SDG goal of having under 25 is within our grasp. And already several states are at SDG goal, and many more will achieve SDG goal. So for both the under 5 mortality and maternal mortality, which is the core of how the system and public health system should work, we can be proud of what our efforts are, and we are on track of achieving NMR reduction of below 12 on track. Urban India has already achieved the SDG goal for neonatal mortality rate of below 12. 6 states have achieved it. Just to say that this nation is working hard. I just also want to add to this that we believe that in this phase of the Honorable Prime Minister's Modi 3.0 कालखंड जो है उसमें we will achieve the elimination of following diseases from the face of India. Number 1, TB. Number 2, leprosy. Number 3, lymphatic filariasis. Number 4, Kala Azar. Number 5, mumps. Measles. Measles, number 5, and rubella. And we'll perhaps be also very close to eliminating malaria. I repeat, these diseases will disappear from the face of our nation before 29. TB, leprosy, lymphatic filariasis, Kala Azars, measles, rubella, and very close to eliminating malaria, and perhaps eliminating malaria. Then we'll do the certification phase to reach the goal by 2030. We already eliminated trachoma, got certified very recently. As you know, neonatal tetanus has been eliminated, and we all, of course, are witness to smallpox eradication and polio eradication. This is just to give a glimpse that things are moving in their own way, and we can be proud of what we are doing collectively, because this is nation's achievement. This is not a government's achievement. Every government, every society, all the period of time, and every one of us have played a role in this regard as citizens. I want to touch upon the rare diseases in a minute, because I need to consult I saw it, so I want to start again with optimism. About 3 years ago, I had the opportunity to sit with the clinical genetics fraternity of India and other people, and we decided they decided, in fact, that there are 13 diseases that they think are critical for us to work for in terms of their solution. These can be grouped into three subgroups. Those that require small molecule therapies, which are simpler. Those that require genetic therapy, those that require enzyme therapy, the tougher part. Sure, those are more horrible diseases, I accept that. But that's the list we created. So we have tyrosinemia, Gaucher's, Wilson's, Lennox-Gastaut, PKU, hyperammonemia, cystic fibrosis. These are small molecule diseases. They prioritize spinal muscular atrophy, Duchenne, achondroplasia for genetic therapies, Pompe's, MPS, and Niemann-Pick for the gene therapy. The point that I wish to make very briefly is that systematic work in its own way is underway, and there are, of course, other facets to this story. I'm happy to inform you that for the following 4 drugs, for the following conditions, the small molecule drugs have now become available, which were not available till, let's say, 1.5 years ago. These are, for tyrosinemia, we now have India-made NITI. Gaucher's, we have capsule iliclustat. We have for Wilson, trientine, and for Gastaut-Lennox syndrome, cannabidiols. These 4 have become available. For Gaucher's, the other drug that was highlighted by them, capsule miglustat, is being, by an Indian manufacturer out there, is being already submitted to FDA, and once they approve in the next 2 months or so, this will also become available for import in India. So 5 drugs, and simultaneously worked on oral preparation for hydroxyurea for sickle cell disease that wasn't available. I just want to give you a sense of cost that will be offered, because that's a very important issue here. I'll give only 1 or 2 examples. Here is an example on let's say, trientine. The cost for therapy per year for a typical child was 3.2 crore, which is now 3.5 lakh. It's 1 by 90 differential. Please give me ideas on how to make it accessible, because these are available, already being prescribed, but we need to open more pathways. One more example let me take. This is nitisinone. Cost was 2.2 crore and now down to 3.7 lakh per annum, 1 by 60. And last example, there are others, but let me pick up on the syrup hydroxyurea. Syrup form was available 70,000 rupees per 100 ml. It will be available for 1,200 rupees per 100 ml, whatever the differential is. You may then say, what are we doing for the tougher ones? The answer to that is, these are not easy things that happen. The cost that companies incur in their R&D journey, they then extract out of us with that huge price that they tag. But now we have hope, because you have seen last year 2 important developments. One, that for resistant leukemia, lymphoma, Tata Cancer Hospital, IIT Mumbai have come out with CAR T therapy. So we have broken this glass ceiling that we can manipulate that level of the cell. Number 2, from CMC Vellore has come up a cure based on lentivirus platform for hemophilia. I'm aware of at least 4 companies that are now into creating cell and gene-based therapies. And cell and gene-based therapy mission has been proposed by NITI and the Office of the PSA as a national mission, and we are working on it. So we have the scientific capacity, and I think we have reached that inflection point, and we have the industry coming together. I understand one particular industry, won't name, already working on something like 5 approaches, and they get technology from another country, they get people from there. They're not telling too much about it, but on their anvil are therapies like thalassemia, for conditions like thalassemia, cancer and others. I also want to add here that CSIR is working on CRISPR-based therapy for sickle cell disease, and a very major effort is on. I believe the patient enrollment could happen this year as phase 2 trial, and then we move to the next phase. The point that I am making is that we have to develop these capacities on our own ultimately. और वो जब तक नहीं होगा ये कॉस्ट और ये सब कुछ चीज़ें कभी भी पूरी नहीं हो पाएंगी. This must be known for a nation of our size, for the complexity that we have and the number that we have for whatever disease, even rare diseases. People say we must have the largest number of rare diseases in our country because of the population. That's it, very simple. So we have to rise to the occasion, and here we should draw lessons from COVID. 220 crore, 2.2 billion plus doses were administered. With vaccines, all of them, all the doses made on the soil of India. Imagine, shut your eyes, if that wasn't produced in India and India did not have the scientific capacity and the industrial base, we would have been left high and dry. The vaccination program of India saved 34 lakh individuals in the first year as per the Lancet estimate, the global estimate in which India estimates available. 34 lakh lives were saved. Vaccine produced in India and delivered with the help of all of us, all of you, all of us. I just want to also mention here that I was part of the negotiations for what was being offered to us by way of other vaccines. So we'll talk to them and say, please give us vaccine. They say, okay, third quarter of 21. तब तक क्या करें? अपना तो कर ही रहे थे. Short story ये है, if what we got was, and even if you believe the Johnson & Johnson single dose vaccine was effective, okay, assuming that, we had offer of only 90 million patients, individuals to be covered, 9 crore, and our adult population was 1 billion plus, 9 crore and 100 crore. हमें कहीं से, अब देख लीजिए, अगर नहीं बनता, प्लीज शट योर आइज एंड सी द काउंटर नैरेटिव. 9 करोड़ मिल रहा था सिर्फ, एंड वर्ल्ड कुड हैव नॉट डन इट बिकॉज सिंपली देयर वाज नॉट दैट लेवल ऑफ प्रोडक्शन इन द वर्ल्ड. इतने बड़े देश को कोई दे ही नहीं सकता. तो मैं सबमिट करना चाहूँगा, हमें खुद ही बुलंद करना है अपने आप को. यही है, चाहे वो रेयर डिजीज़ की बात है, चाहे ग्रेट हेल्थ सिस्टम की बात है, चाहे दवाइयों की बात है, चाहे मेडिकल कॉलेजेस की बात है या एक्सपर्ट्स की बात है, जो भी टेक्नोलॉजी की बात है, हमें अपने पैर पे ही खड़े होना है. यही फिलॉसफी हमारे प्रधानमंत्री हमें कहते हैं, इसको फॉलो करिए. थैंक यू एंड बी पार्ट ऑफ दैट जर्नी. एंड आई विल कम टू दैट कि आपने क्या करना है, अभी थोड़ी देर में आ रहा है वो भी. Now I wish to address the broader issue that has been brought here. And I would say, what are ultimately your patient rights हैं और patient की satisfaction है. It has a fundamental principle, first the access and then of course quality and affordability. Access and affordability, I'll cover that to an extent. It's not a counter at all. I'm here, I'm together, it's a round table. We're not different at all. Just to tell you the context, let's tell you the things that are being done most earnestly. So in terms of access, let me start with, the beds, for example. In the last 10 years, medical college beds, because that we have the specific number. When we started in 2013-14, there were 387 medical colleges. Today, there are 780 medical colleges. More than double. But more important, at that time, the government medical colleges were 181. Today, they are 431. 250 medical colleges have been added. The point I wish to now add is, if they have on the average 300 beds, you have 75,000 beds in the secondary space, additional beds today. 75,000 beds. Of course, private, 143 medical colleges were added, and the distribution was changed from private government like this to now clearly government dominant beds, medical colleges, and therefore beds. 22 AIMSs, typically 800 beds, that's about 17,000 beds. We move further. Madan Gopalji may have better estimate, more updated estimate from NHSRC and Ministry. Under PMA BHIM, building on the critical care blocks, 35,000 beds will be added in the critical care segment of India, in district hospitals and medical colleges. Under a plan which was launched during COVID-19, 15,000 pediatric intensive care beds are being added. So please add these 50,000 beds more, and so on. Just to tell you, these are just examples of how much push is there on hospital infrastructure. Concomitantly, the providers have also increased tremendously in this period of time. The number may pop up here because these notes I was taking as you were speaking to be able to contextually correct. So that's one way of looking at it. I also want to emphasize here that perhaps the most important part of our infrastructure is that India is building future-ready, comprehensive primary healthcare system. And because we are most urban here, we may not know a great revolution that is taking place on the ground. We have always had these sub-centers from the Bhor committee, sub-centers and primary health centers. That vision was rightly set, about 6,000, 5,000 to 8,000 population for sub-center, about 30,000 population for primary health center. We did what we could. We achieved several things. There was a focus on family planning, maternal child health, and smallpox and communicable diseases. We did what we did. In 2018, Ayushman Bharat Health and Wellness Center mission came up alongside the PMJ mission, which I'll come to very briefly in a short while. Under this mission, we are creating what we now call as Ayushman Arogya Mandirs. Health and wellness centers are now called Ayushman Arogya Mandirs. I want to tell you, silently, because it's mostly rural as of, 174,000 previous sub-centers and PSCs have been upgraded to Ayushman Arogya Mandirs. What will they do? We were providing maternal and child health and communicable disease, newborn health, and hub for primary care and outreach through ASHA workers, 1 million of them. Now adding non-communicable disease, senior care, mental health, eye, ENT, oral health. In terms of the screening, in terms of the core non-communicable diseases, hypertension and diabetes, and 3 cancers, oral, cervical, and breast, screening is mandated as per protocols. For hypertension and diabetes every year, and for cancers as per the, every 5 years. The point that I wish to make is that it's happening today. Again, journey is not complete, but it started to happen. 174,000. All of them have telemedicine facility. And at the sub-center health and wellness center, 140,000 of new community health officers, typically BSc graduate nurses, have been put in place to serve the nation. आप इसको इसमें ताकत डालिए. This is the most important part of our health system today. आपने सुना शायद ज़्यादा नहीं है. I want how you can help it. These health and wellness centers are also coming up in the urban areas. There will be a different way of delivering it because the paradigm changes, but the principles remain the same. This is where primary prevention will be pushed. This is where secondary prevention, early detection. The person doesn't know that he or she has hypertension. अभी हमने सुना, पता ही नहीं. साल में एक बार ही करेंगे तो पता चलेगा. फिर कंट्रोल की बात आती है, फिर कंप्लायंस की बात आती है. So this is where the NCD battle will be won, apart from whatever best we can do through primary prevention, which means food and exercise and no tobacco, this, that, not going in that direction. I want you to support that effort and know that this revolution silently is taking place. I encourage you to visit some of the health and wellness centers and encourage you to be partner in improving their care and services. Now let me now touch upon the Ayushman Bharat PMJ a little bit, because that is an instrument of increasing access. I want to take that part first. As you know, Ayushman Bharat PMJ covers the 40% lower, two lower quintiles essentially, providing a cover for hospitalized care. Primary care is typically ambulatory. Hospitalized care through PMJ. And if you put it together, this is the design that nation is following for UHC, Universal Health Coverage. Primary care, government, through primary health centers that I talked about. And secondary, tertiary, through a partnership of private and public hospitals, 31,000 of them working together. But the private sector services are purchased on a very, very rational basis. Now, how much population is covered? We started with 50 crore individuals, 12.72 crore families, raised to now 55 with the increase in population. What you may not know is the following. Then the state, additional population picked up by the state is added on to this. This is the shared part where union and state bear the financial expenditure. That's 55 crore population. Then states add their own. Some states have said everybody, J&K, Uttarakhand, and so on. If you add all that, today, 67 crore people are covered under PMJ system. And to this now add more than 70-year population of any economic group. Half of India is under the ambit of free care up to 5 lakhs or more for secondary tertiary care through 1930 packages. That's the coverage that you already have. Is it perfect? No. Is it good? Yes. It will become perfect. ठीक हो जाएगा. फ्रॉड भी हो रहा है कहीं पे, थोड़ा बहुत होता है. सर्विसेज में इश्यूज हैं, हमारी साइड से भी हो सकते हैं, प्रोवाइडर की साइड से भी हैं. Satisfaction? No. But this is the journey that we have taken. But today, half of India, please understand, half of India population is covered for secondary, tertiary care, including kidney transplant, by the way, and all cancers. Let's make it perfect. And under this, just a few numbers, and then I would move to the next part. How much? Well, from the numbers that I have, yesterday 24,000 admissions took place. And 1 minute. Okay, total of 8.6 crore hospitalizations have taken place till now, 8.6 crore. Yesterday, 24,800 admissions took place. Imagine every second how many admissions are taking place. And 1.2 lakh crore rupees have been authorized for payment for these beneficiaries. 1.25 crore has been authorized. We have at least 2 studies which show that this is making a difference. A study done by a group at Chandigarh, but working with 7 healthcare facilities in 6 cities, shows that timely treatment for cancer treatment initiated has improved in those who receive PMJ benefits more than the general population. So what they estimate is that timely treatment for cancer has improved overall between 2 periods that they compare. It has improved by 33% who are not enrolled in PMJ, but it has improved by 90% in those who were enrolled in PMJ. The point is PMJ is allowing you to seek care early, even in a complex disease like cancer. So this is happening already. And Shamika Ravi's work has shown that there is a 23% reduction in the odds of household facing a decline in consumption due to health care in those who are in the geography of PMJ. Out-of-pocket expenditure, as you know, from 64% of total health expenditure in 2013-14 has declined to less than 39.4. So the affordability has improved. And to this, if you add free dialysis, crores of sessions that have been held, 3.27 crore sessions have been added. And if you add PM Jan Aushadhi system, which has accrued more than 28,000 crore to the people through drugs, medicines that are being sold at 50 to 80% discount, and so on and so forth, I want you to appreciate that there is a huge effort to improve accessibility and to improve affordability in fullest earnest at least in these 10 to 11 years of time. Having said that, 2 brief points now. One, I think we need for this community in particular, the middle classes that we are represented here, we need a more generous and more, shall we say, patient-friendly or family-friendly insurance coverage system. We are working on that. The insurance options that are available should become more accessible to lower middle class in particular. There are challenges in that, and we are working on that. I would like guidance of the groups like yourselves, how to do it. How do we do it? To provide a cover of 5 lakh that PMJ provides, typically the annual cost, even for when we scan these various insurance companies and their products, is typically about 25,000 rupees for a family coverage. That's really not conducive to many. How can we do a better deal? But I also want to say that in the last 2 years, the Insurance Regulatory Authority has opened up many opportunities and they've become more liberal, so we need to cash on that opportunity. My last point is that we are together in this journey, and therefore we need partnerships. What is it that we can do more collectively, other than guidance, other than giving the inputs to the policy enablers, including all of us? This helps us a great deal. So that's one part that must happen systematically. Tell us how to improve. But at the same time, I request that please connect and see how best we can do for health and wellness centers. अब जरा देखो तो सही, मदद तो करो. Can we improve the footfall there? There are 106 free medicines and 14 diagnostics at sub-health center level, and 43 diagnostics and 172 free drugs mandated through the system. उसको इस्तेमाल करवाइए, उसको यूज़ करवाइए, उसमें मदद करिए. वहाँ पे एल्डरली के लिए फ्राइडे की आफ्टरनून में एक सेशन करवाइए, केयर ऑफ द एल्डरली करवाइए, हेल्थ प्रमोशन करवाइए उस साइट को, तभी तो फ़र्क पड़ेगा. इतनी जो चैलेंजेस हैं तो उसमें हमें मदद है. मैं एग्जांपल दे रहा हूँ थोड़ा सा. एम्स का बार बार जिक्र हुआ, मुझे बहुत अच्छा लगा क्योंकि मेरे पेरेंट इंस्टीट्यूशन है. आपने अच्छी रिपोर्ट दी है. जनरली कहा जाता है कि उसके बाद पेशेंट्स हैं रात को सोते नहीं, तो किसने करना? वो एम्स के बजट से या एम्स की सोसाइटी क्या कर रही है? क्या हम उनको लुक आफ्टर नहीं कर सकते? कहा जाता पता नहीं चलता तो बोर्ड लगा दिए, कुछ कर रहे. उनको और करना चाहिए, ज़रूर करना चाहिए. हम भी कुछ कर सकते हैं क्या कि हम फैसिलिटेट करें? आई डोंट सी an army or let's say a troop or a battalion of volunteers there कि आप इधर जाइए, यहाँ जाइए, ऐसे मदद करिए. क्यों नहीं? ये भी सोचा जा सकता है. और एम्स में भी हम ऐसे कुछ कर सकते हैं क्या? कैंसर के स्पेस में कैन किड्स और इंडियन कैंसर सोसाइटी काम करते हैं, और सेगमेंट्स में भी करना अच्छे भी हो रहे हैं. अवेयरनेस के बारे में बात हुई है. थैलेसीमिया के भी ग्रुप्स हैं जो कर रहे हैं. कैन वी डू मोर? Can we do more to at least to ease the pain of the families? Because सारा हेल्थ सिस्टम अकेला कैसे उठा सकता? सोसाइटी को भी आगे आना चाहिए, और वो पार्टनरशिप्स की बात कहूँ चाहूँगा. एंड इन दैट रिगार्ड वेरी बिग एरिया इज अवेयरनेस. डायबिटीज़ की अवेयरनेस का एक कोई डॉक्टरों ने ही तो नहीं पहुँचाना है, सोसाइटी ने भी करना. पब्लिक से कर रहे हैं और भी करेंगे, वो जिम्मेवारी से हट कोई नहीं रहा यहाँ पे. लेकिन क्यों नहीं उसकी जानकारी हम आगे तक देते? क्यों उसकी कंप्लायंस की बात नहीं हम करें? क्यों हम ओबेसिटी पे, अभी प्रधानमंत्री जी ने आह्वान किया है ओबेसिटी पे, हम सब जुड़ जाते हैं. ये जो खुराक का इशू चला हुआ है, फूड है हमारा, सब उसके बारे में हेल्दी फूड की बात करें. एक्सरसाइज. कैन वी नॉट बी हेल्दी सोसाइटी? हाउ कैन वी यूज आयुर्वेद, आयुष सिस्टम फॉर अवर बेटरमेंट? हाउ कैन वी लुक आफ्टर the elderly? How can we give better deal to the mental health of our colleagues, of our workplace, our school, our children, and so on and so forth? इसमें बाकी हम कितना जुड़ सकते हैं उसका भी अभी कोई अंत नहीं है. मतलब इनफिनाइट है वो मदद अगर हम इकट्ठे करना चाहें. उसके पाथवे भी लिमिटेड दिखाई देते हैं. मैंने सिंपल एग्जांपल दिया कि हम सब ने कहा कि एम्स में भीड़ होती है, अखबार में रोज़ कोई वॉलंटियर आके नहीं कहते कि हम यहाँ लाइन लगवाने में मदद करेंगे. शायद हैं तो बता दीजिए, वी विल कनेक्ट यू. तो कहने का मतलब ये है कि इस पार्टनरशिप में आगे बढ़ते हैं I think very major steps have been taken. These 10 years will be seen as an inflection point, particularly 2018, two announcements that happened in the budget speech of Jaitley ji. Under the leadership of the Prime Minister, you have the vision for universal health coverage, a strong primary health care, and secondary, tertiary hospitalization, health assurance through that system, which I told you the level of coverage that we have today. And it is an example. At the same time, India has, of course, the strong pharmacy of the world. We would be a medtech manufacturing hub. So we have these capacities, and we will crack the cell and gene therapy as well in the next. You will see the results in the next 3 to 4 years, I assure you. With these words, I thank you once again for the opportunity. Thank you indeed. Thank you.